Okay, so we'll do some questions that we've received so far. We had one submitted by email, and then I have some questions too. Rachel said, I often come across the term living with myeloma. Is this term relevant to the younger than average patient who achieves a stringent complete response following a stem cell transplant? Would he or she expect to experience fatigue or continue to note bone degradation during remission? Are chances of infection still more likely than a normal person, or are these effects of active myeloma? And either one of you or both can respond.
Maybe I can start. So we have actually patients that received a transplant or a tandem transplant more than 20 years ago, and they are still in complete remission. And they lead a completely normal life. They actually never had any maintenance therapy either. So they are free of any anti-myeloma agents now for more than 20 years. So I think especially in a young patient who received a transplant, went into complete remission, maybe today we can measure MRD and maybe MRD negativity. I would predict that this patient actually has a quite good chance for long-term disease-free survival, maybe cure.
That's good to know. Dr. Nahi, do you have any comments?
No, I totally agree with Professor Ansela. I mean, we have during even in early days, we have about 8 to 10% of myeloma patients undergoing high-dose treatment that they never get a relapse.
Okay, another question from Yanni. My question is directed to Dr. Nahi. The results of the COLUMBA trial, phase 3 for relapsed refractory myeloma patients show that Darzalex Faspro the sub-Q shot is about the same as Darzalex, and it's recently been approved by the FDA here in the United States. So in Europe, or in especially Sweden, what timeline would you anticipate for availability?
Well, it will be very soon. It will be after midsummer, as you mentioned, because on the going pandemic with COVID. So we are getting a huge help from Janssen to introduce the sub-Q almost immediately, the next week or the week after, actually. So it will be implicated very soon for the care of the patient, that the patient can get it in by the nursing houses, by the GPs. So we will give the drug to the patient and to be administered at home.
Okay, just so everybody knows, so that's a subcutaneous shot of Darzalex instead of the longer IV infusion. So that makes treatment just a lot more convenient and nice, and it shows the same efficacy.
Well, the same effect. I mean, the study is designed as a non-inferiority study, but we see actually a higher response rate, and the side effect, the infusion reaction, is 10% compared to 40-50% with intravenous preparation. So it's more favorable for the patient to use the sub-Q. I'm quite sure about that.
Okay. And then you talked a little bit, Dr. Nahi, about KRD versus VRD in newly diagnosed myeloma patients. And you're saying the standard is basically VRD that you'll be using. And we had a question by Daniel that said he had been suffering from asymptomatic IGg Kappa myeloma since 2016. And he's 74 and has 70% plasma cells 4 years ago. And what's the variable, he's wondering, that makes treatment begin? And he's followed by a French doctor, hematologist.
I mean, this is well defined today. There is a lot of studies both from the US, from the Spanish group. When the start is the myeloma defining criteria, as to say, by doing the MR on the skeleton to see if there is a lesion. It's the measurement of the IFLC. So it's well defined. Knowing that had been gone 4 years from the diagnosis, I'm hopefully that it will never occur that this patient will be a treatment demanding. We know that more than 50% will develop with treatment demanding disease within 2 years, and the longer time it is, the lower risk to develop a treatment demanding myeloma. Was that an answer?
Yeah, great. Thank you. Okay, and I had a question too, because both of you talked a lot about CAR T, and maybe Dr. Nahi, you want to go over the names of the CAR T? I think people kind of get confused a little bit about different results in different studies. So one of the questions was, are these studies that everyone has mentioned, all the CAR T studies and other studies, available in the United States, or are these just European studies? So I'll let both of you answer that question. But then additionally, just mention the CAR T names, I guess. I think that gives people a little better connection. Then I have some follow-up questions about CAR T.
Actually, the situation is like this, that in the US, patients have much more access to CAR T cell therapy than in Europe. So I can congratulate you. You are living in the country where you have the best access to CAR T cells. There are a few CAR T cell products like our COLUMBA trial, where we use SLAMF7 CAR T cells, which is, because it's funded by the European Commission, is restricted actually to Europe. But there is a company also in the US that is using SLAMF7 CAR T cells. So most of the CAR T cell products are actually ongoing in the US. So the CAR T cell product, which is the most clinically developed one, is the so-called ide-cel product. That was tested in the different KarMMa trials. It's developed by BMS Celgene, and one study with 140 patients actually has been finished, and the data have been shown at ASCO and EHA. And in this trial, it was shown that the toxicity of CAR T cell therapy in multiple myeloma is much less when compared to lymphoma or ALL therapy. The issue is that the persistence of the CAR T cells is limited, that in some patients, the target molecule BCMA is lost on the myeloma cell. And these both reasons probably explain why about 50% of patients, often after successful therapy, because response rate is more than 80%, that these patients actually relapse with their multiple myeloma. One of the reasons why the patients are relapsing, when probably more when compared to lymphoma, is that in the current trials, most of the patients that received CAR T cells were extremely heavily pretreated. So 7 or 8 lines of prior therapy. And we know that all other strategies or drugs or combinations you use in these patients only give about a progression-free survival of maybe 2, 3, maximum 3.5 months. So CAR T cells are very, very effective. And to make them more effective, I think we have to move them to earlier lines of therapy. And that's happening now in several trials. Apart from the ide-cel product, there's also a product from Janssen, tested in the CARTITUDE trial called J&J and a long figure. And this product is also very successful, and about 29 patients were now treated. And there are a lot of studies ongoing in China. And one of the study with the longest follow-up was actually performed in China, the so-called LEGEND trial. And this trial, also a very high response rate was reported, and they actually have a progression-free survival of more than 2 years. The reason probably why the results are better in this Chinese trial is that in China, they don't have as many novel agents as there are available, especially in the US, but also in Europe. And there are a lot of other products now also coming in early clinical development. And I pointed out a few of these specific things like humanized BCMA targeting domain and so on.
Mm-hmm. And I wanted to follow up and ask you a little bit more about that, because at the beginning of the program, you were talking about this earlier use and maybe of BiTEs as well. And you mentioned that. So could you think about what else would you do at the beginning? Like, you know, right now we start VRD and stem cell transplant, maintenance therapy, and we go on. But if you did a CAR T up front, what kind of things would you do for follow-up? Would you do a stem cell transplant follow-up? Would you do just a maintenance therapy? Would that be CAR T maintenance therapy or just kind of the standard drugs? I mean, you have so much expertise, both of you, in this, just the management of myeloma in general. We have this arsenal. How would you deploy that?
So that's a great question, but also a very difficult question to answer. So I think that the main point is, and I think we all have to consider that we would all love to cure multiple myeloma. I think that's the goal. And we have now tools that allows us to do it. And I think we have to optimally combine what we have. Now we know from every immunotherapy, and if we go back to the old days of allogeneic stem cell transplantation, which is also a kind of immunotherapy, it is very important to reduce the tumor load as much as possible before we start the immunotherapy. So I guess that we have to do some very effective therapy, for example, VRD, daratumamab, or KRD with daratumamab, or another anti-CD38 antibody to reduce the tumor load as much as possible. Maybe we can omit transplantation and then go in with bispecific antibodies or CAR T cells. And then we have to see what happens. Probably at the moment, I would use also transplant and probably put the bispecific antibody and the CAR T cells after the transplant. But it could well be that we are so effective that we can actually omit the transplant. What can we do after BiTEs or after CAR T cells? We have to see. There are some data that maybe immunomodulatory agents like IMiDs or the modern CelMoDs, this is the next generation Revlimid, pomalidomide, that these agents might actually increase the efficacy of the CAR T cells by prolonging their persistence and make them more effective. So for me, the future strategy could be a very good induction, VRD, KRD plus an antibody, maybe transplantation, then CAR T cells or bispecific antibodies followed by a maintenance therapy.
And would you wait for first relapse for that CAR T or the BiTE after transplant? Just go.
I think I pointed out we have patients now that are 20 years disease-free, but as Harriet has very nicely pointed out, it's still, unfortunately, a minority of patients. So I would use CAR T cells or bispecific antibodies in the beginning, especially in high-risk patients.
And how
sorry, I totally agree with Herman. I mean, when we reach a 90% disease freedom or relapse-free survival in 10 years, then we can talk about minimizing the treatment. There are some ideas ongoing in the Nordic myeloma study group. We are planning for a study to introduce BiTE already after the high-dose treatment as a maintenance treatment during a long time. I know that there is a CAR T program to be given after the high-dose treatment as a consolidation. So we have to go this way. I mean, most of patients with standard risk, they have a long PFS. But patients with high risk, they need intervention in first line and not later on, as Professor Ensler mentioned.
Well, I like that strategy. Like, let's get it to work first and then dial back. You know, Okay, so Ken has a question that's kind of related, and this kind of addresses the high-risk myeloma. So he's on CAR-T maintenance for a year following four rounds of CAR-T and a stem cell transplant using ELO with NK cells, or elotuzumab with NK cells. So on the 17 deletion and he has 17 deletion with light chain myeloma. So if he sees progression with that type of therapy, do you do elotuzumab or daratumamab in addition as a stronger approach, or what do you do from there?
This patient seems to be really so. 70p is a bad risk features, but today we know that probably if both alleles, so you have two chromosomes, and on two chromosomes you can potentially delete the part of the set of the chromosome, and that's a 70p deletion. So you can have one chromosome which has a 70p deletion, and the other one is normal. But you can also have a 70p deletion and a 70p deletion of the other chromosome, or a genetic alteration of this gene region. And then the negative predictive value for an outcome is much worse. So I think that could be an additional analysis that should be performed in this patient. He has received a very effective treatment with KRD, transplant, now NK cells plus ELO. I think this is a very modern and very effective treatment. So if he would relapse, I would probably consider this patient to be a candidate for a CAR T-cell therapy or a bispecific antibody. Harriet, what would you think?
I totally agree. Actually, I just included the patient with 17p relapsing after high dose treatment and a good maintenance in the BITE, and I'm surprised by the response that he got from this treatment within few weeks in BGPR already. So I totally agree with you.
What BITE are you? What's the name of the BITE that you're working with?
Oh, I have we have three programs for the BITE. The one that I mentioned is the same as the presentation from Dr. Sadusmani. I'm participating in this study. It's the Johnson project.
Okay, and the name of that is I'm not going to say it right. Okay, just say it again.
Teclistamab.
Okay, got it. So that's a new BITE therapy. In high-risk myeloma, when should you use the quad therapy? And Dr. Einslow, what you were saying in your approach, in using even CAR T, you were using a quad up front, maybe stem cell transplant, CAR T therapy, and so on. So do you see the quad therapies being used just for high-risk patients, just for everyone? Because it seems like adding that extra, that isatuximab, like he was mentioning in that trial, or the daratumamab up front doesn't add a lot of extra toxicity to the triplet. So maybe you two want to address, when do you use quad therapies?
Okay, so with quad therapies, you mean quadruple therapy, right? Yeah.
Right.
Okay. Yeah. So I think we have now quite a lot of data that are supporting to add a monoclonal antibody to a triple combination. We have data with VRD, VTD plus daratumamab from the French cooperative group, and they clearly show that adding daratumamab improves, especially complete remission, improves especially MRD negativity, and also improves progression-free survival. We know from at least one trial, the Griffin trial, that adding daratumamab to VRD improves response rate, improves complete remission rate, improves progression-free survival. And there are several ongoing trials that are also using KRD with isatuximab, KRD with daratumamab. So I guess that, and actually VTD plus daratumamab is already approved in the US and in Europe for induction therapy. And also for the non-transplant eligible patients, we have RD plus daratumamab and VMP plus daratumamab. So also antibody combinations. And I guess that the frontline therapy in the future really be a quadruple therapy for the young transplant eligible patients, and a quadruple or RD plus DARA, or maybe VRD plus DARA also for the non-transplant eligible patients. But maybe, Harriet, you could also comment on this.
Herman, as usual, I totally agree with you again. I mean, as Jennifer said, the CD38 do not add on side effects. So, so improving effects and response rate, it will be beneficial for the patient. I'm totally in line with that. So the approval is already there for the elderly, and we will start practicing the addition of anti-CD38 to the VRD induction in Sweden in a very near future. So I'm quite sure about that. Would that be enough for the high risk patient? Probably not. We will probably need to either maintain with the BITE, with the CAR-T, or to start with, when these two are not yet available, we probably need to maintain with both lenalidomide and the anti-CD38, plus minus an PI. We need to have a medication that don't give that much side effect and will hopefully prevent relapses, mostly in the high-risk patients.
And Dr. Moreau, we were doing an extension of what you were starting to discuss in terms of quad therapy, like using isatuximab. And I was just asking the doctors if they see quad therapy or using 4 drugs in combination as a standard of care, basically, and moving that up to, you know, front lines, and for whom, like high risk or everybody. So maybe you just want to continue your conversation.
Thank you. I'm really sorry about this technical issue. In fact, I was telling you that we are going to run this study with a quadruplet combination up front, 6 cycles, and looked at minimal residual disease negativity systematically for all patients after 6 cycles of the quadruplet. And those patients MRD negative at 10 to the -5 with therefore a very, very good response, we are going to randomize again stem cell transplantation versus no stem cell transplantation with 6 additional cycles of quadruplet without stem cell transplantation. And then patients will receive 3 years of maintenance with iberdomide. Iberdomide, that is a new drug, a CelMoD, that is more active, an oral drug, very similar to the IMiDs, in fact, and more active as compared with pomalidomide. And the goal of this randomized study is to show that we can upgrade the quality of the response and the MRD negativity rate to 10 to the -6 for many, many patients. And we will also would like to demonstrate that we can reach sustained MRD negativity during a long period of time, at least 3 years. And we are anticipating that with the duration of MRD negativity that will be roughly 3 to 4 years, some patients will be cured without any relapse. So this is our goal in our future study. And back to your question, yes, definitely I think that we are going to use quadruplet combination for young patients, at least in the future. We also already have some interesting data with VTD plus or minus daratumamab and stem cell transplantation, and we have published those data based on the Cassiope study. And we have shown that with a quadruplet combination, the progression-free survival is highly improved as compared with the triplet. And other data are coming as well from the US with VRD plus or minus daratumamab and stem cell transplantation. And definitely with a quadruplet, we have better results in terms of response. Those data were recently published by our colleagues from the US, the Griffin study, in a very important journal, Blood. And there is another very large study that is ongoing in Europe, raising the same question, VRD plus or minus daratumamab in the setting of stem cell transplantation.
Yeah, I love that approach. So like get it early and knock it down, and let's see if you all can extend these remissions for patients for more than 10 years. Because I know some patients are getting 10, 12 years with existing therapies, and maybe we can make it even longer. And maybe we can help the high risk patients too. One of the questions from, did you want to share anything else before we go to questions, Dr. Moreau, in terms
No, we can go to questions if you
Okay.
want, yes. Yeah.
So Adrian had a good question about going from MRD positive to MRD negative. So he said, in your clinical experience, do you change the treatment once a patient turns MRD positive from MRD negative? And that's a really good question from patients.
Well, definitely, these are the most important questions. Can we use minimal residual disease to alter therapy, to change the treatment either when the MRD is remaining positive after a specific treatment, you want to increase or to change the treatment to reach MRD negativity, or in a patient with a MRD negativity assessed several times, twice or 3 times consecutively, can you stop the treatment, for example, like we are doing in other hematological diseases? In fact, in France, we are not using MRD outside clinical trials because we are thinking that we need to have the results of the ongoing studies looking at those specific questions about the role of MRD to change the treatment, yes or no, to stop the treatment, to propose a more aggressive strategy in case of MRD positivity, for example. So many studies are ongoing worldwide with many cooperative groups looking at this specific question. So since we don't have data strong enough to our opinion to try to change the treatment, yes or no, we would like to wait a little bit, and then we will run systematic MRD analysis outside clinical trials.
Yeah, okay, that makes sense. Dr. Nahi and Dr. Einsela, do you have any comments about that topic?
Well, we are following MRD outside clinical trials. And I mean, as a treating physician, looking at patient converting from a negative to a positive status, it's kind of itchy. You need to do something for the patient's sake. So the thing that I'm practicing is more careful monitoring of the M protein. So instead of taking it every second month or every third month, start taking it every 4th week, just to start a treatment as soon as possible. But as Philippe mentioned, we don't have the trial that is showing the positive effect of changing regime or starting treatment earlier. There is always patients that are fast progressors and patients that are very slow progressors. So the patient that is slow progressing, it might take a year or 2 before they become treatment demanding. By monitoring them more carefully, we will pick up these patients that are fast progressors and start treatment as soon as possible until we know better.
Okay, great.
So we also use MRD measurement as a kind of a biomarker. And I think what we know is that patients that achieve MRD negativity, especially when confirmed by additional imaging, especially using PET-CT, and Philip has very nice data from the Cassiopeia study that if you have MRD negativity at a high level plus a negative PET imaging, that these patients have a very good prognosis. And so I think we should, in all our studies, and we have now, fortunately enough, a very long progression-free survival. So if we want to change things, if we want to improve our therapy, it would be difficult always to wait until we have progression-free survival as an endpoint. So it would be very nice to have MRD negativity plus negative imaging as an endpoint of a clinical trial to really compare the efficacy of different trials. So I think it's a very important biomarker, and it helps us to predict the outcome of patients. If a patient loses MRD negativity and becomes MRD positive, I think it's a signal which we have to follow up. But I don't think we really have data that we can actually base any therapeutic decisions on a change from MRD negative to MRD positive. But we would definitely follow up this patient very closely to see whether he then has a biochemical and maybe also a clinical relapse, and then of course into therapy. But I think it's too early at the moment to really base a therapeutic decision on a change from MRD negative to MRD positive.
Okay, well, that's good to know. And I would love to see MRD. I love how you're talking about MRD negativity plus the PET negativity to have this new endpoint, because your studies are getting really long.
Yeah.
In terms of like what you're looking at in outcomes, and you're looking at these studies that might last 8 or 10 years instead of trying to use that shorter time period of MRD negativity or positivity or negativity. That's great.
But Jennifer, if I may, we are going to use MRD as well in the near future to look at the efficacy of new agents. For example, we are currently proposing to some pharma companies to have CAR-Ts proposed after a very aggressive treatment, frontline stem cell transplantation, for example, and for patients remaining MRD positive, for whom we know that they are going to progress. We would like to use CAR-T to convert from MRD positivity to negativity. So to show that we can definitely improve on the depth of response, the quality of response with a new agent. So MRD will be very important, a surrogate marker, a biomarker like discussed by Herman for PFS, OS, but also will help in the assessment of response and the evaluation of new agents.
Okay, that's great. I hope that happens sooner rather than later. So, Dr. Einsel, you at the beginning you talked about maintenance therapy, and Rachel had a question: have there been any updates on maintenance therapy post stem cell transplant? And you talked about potentially using like a monoclonal antibody or something as maintenance therapy. But so there are a lot of questions from patients about which drugs do you choose and for how long do you use them. With the newer therapies like the monoclonal antibodies, or even some of the, like, I don't think there's enough experience with like bites or things like that for longer term use or whatnot. But can you all weigh in about where you're seeing maintenance therapy go, in what combination, for how long? I know Europe usually doesn't do it as long as the United States, but just share your comments about that.
Yeah, so the approval for maintenance is only lenalidomide Revlimid. And in the official approval in the US and in Europe, it's until progression. But in most of the European countries, we are not using Revlimid until progression. I know that, for example, in France, and maybe Philip can later on comment on this, I think they do it for 1 or 2 years. In Italy, they do it for 2 years. Maybe, Harald, you could comment how long you're doing in Sweden. Also 2 years or until progression? Okay.
Well, we practice MRD analysis at... So.
Oh, go ahead.
Sorry to interrupt you. We actually practice the MRD analysis. If the patient is MRD negative, then we keep on maintenance treatment 1 more year. And if he or she is still negative, then we will end up treatment. But we never end up treatment in MRD positive status or a patient still having a measurable M protein. Then we will use it until progression.
Okay.
So we officially do it until progression, but in a patient that has a MRD negative state and is imaging negative, I would probably also stop the maintenance therapy. Your question is, where are we moving with maintenance therapy? Now, there are some data that you can also use proteasome inhibitors, ixazomib, bortezomib, and maybe in high-risk patients, there is also a tendency to combine proteasome inhibitors and IMiDs, but this is not officially approved. So it's still ongoing in trials. And also, for example, in the Cassiopeia study, which Philip has presented and also published, they use daratumamab, a monoclonal antibody, as a maintenance therapy. Or in the Griffin study, they use Revlimid, lenalidomide plus daratumamab, so a combination of an IMiD and a monoclonal antibody. So I think that the tendency will be that we probably have combinations for maintenance, but we don't offer these until progression, but for a limited time period. So for example, in our next German trial, we will probably have a combination of a CD38 antibody plus Revlimid for a limited time period.
Mm-hmm. And Dr. Moreau, what are your thoughts on maintenance therapy?
Well, I think that Herman very nicely discussed this point. Lenalidomide is standard of care, is approved until progression, but we know that many patients are not able to tolerate len maintenance more than 3 years, for example, because of the fatigue, because of the GI toxicity, because of infections, for example. So into the French guidelines, for example, we are recommending lenalidomide maintenance 2 years, but maybe by the end of this year at ASH, we are going to hear about a very important study coming from the US with VRD, auto stem cell transplantation, VRD consolidation, and len maintenance until progression in a very large number of patients. And from what I've heard, in fact, it seems that len until progression is really improving the progression-free survival in the setting of a VRD plus stem cell transplantation platform.
Mm-hmm.
So the goal will be to propose the best option for sure. But now that we will have combinations in maintenance with len plus ixazomib or len plus daratumumab, I think that potentially we are going to try to have a fixed duration of maintenance more and more in the future. So this is a matter of debate. And again, back to the idea of cure. If we have very, very, very good responses, MRD negativity 10 to the minus 6 during 2 to 3 years, I think that we could stop in the future the maintenance and see what happens in fact.
Mm-hmm. Okay, great. You also all three mentioned these CelMoDs. And I think there was a question from Gerald about CelMoDs specifically. He's looking at the option because of neuropathy and some heart issues with Kyprolis. He's had 11 lines of therapy, received CAR T treatment, and had 19 months of progression-free survival. And has the 17 deletion and was diagnosed in 2014. So you can address this specific situation, but I think generally too, he's looking at CelMoDs. What kind of benefit could that provide to him? And I know they're not exactly like the IMiDs. I've heard Paul Richardson say that they're very different, but maybe you want to weigh in on these CelMoDs and how you're seeing them be, of course, they're just in clinical trials right now, but how you would see them being used and what experience you're seeing in these trials. Dr. Mo, do you want to start?
In fact, we have heard about the results of iberdomide maintenance, iberdomide treatment in relapse myeloma patients for now more than 1 year. It was at ASCO 2019 with very, very good results in patients progressing on IMiDs, pomalidomide, progressing on PIs, progressing on CD38 antibodies with good responses. We have heard now about a new CelMod that is potentially more active, coming again from Celgene BMS, potentially more toxic with more hematologic toxicity. So we will have soon 2 CelMods, iberdomide and another one potentially used in combination with other agents. But right now, only clinical trials. We cannot have access in Europe to CelMod outside clinical trials, and that's very difficult to propose such a treatment in a patient progressive, even after BCMA targeting agents.
Mm-hmm. Dr. Nahi, do you have any comments about CelMoDs in general or their use?
Well, Philippe have presented the data, and I totally agree with you. For the patient's question, I would suggest a combination therapy. Why not if it's available to use a new drug? I mean, every new regime molecule that we used in myeloma have just lead to prolongation of PFS and life. But in a 17p deleted, I will not depend on one drug. I would probably combine even older drug that the patients have used as the anti-CD38. We know when reusing it, when the patient already progressed in it, they might have effect in combination. So I would recommend combination therapy, including new agents that the patient never been on it. I mean, every new agent will probably get some kind of remission and prolongation of PFS and survival also.
Right. And Dr. Einsler, do you have any other comments about CelMoDs?
Yeah, first of all, Philip has nicely pointed out the potential of these CelMoDs, that even in patients that are refractory to lenalidomide and pomalidomide, you see about 30% responses with these CelMoDs, and especially with the iberdomide, that it has a lower hematotoxicity. But I think for this specific patient, I think 19 months progression-free survival after CAR T-cell therapy is already a very good success. And what could also be considered in this patient is selinexor. There are some data that selinexor can be effective in patients failing CAR T-cell therapy. And with 19 months progression-free survival, he might actually go back to the sponsor of this CAR T-cell therapy and ask whether he could actually be offered a second infusion of CAR T-cells if there are still some CAR T-cells left, which is the case in some patients.
I didn't know that was available in some drugs. I should probably ask, right? That's amazing. Okay, I have another question from Michael. And this is about CAR T, because all three of you have addressed CAR T in some form. And we've been talking about how to improve durability and different strategies and things like that. But why is CAR T less effective in myeloma than compared to lymphoma or leukemia per se? I think that's a question myeloma patients probably, and you, want to understand.
Yeah, maybe I have a go with this one. So I think there is a difference in the disease biology. There is a difference in the pre-treatment, and there is potentially also a difference in the age of the patients. Most of the lymphoma patients that were treated were slightly younger than the myeloma patients. The lymphoma patients had less heavy pre-treatment when compared to the myeloma patients, who often received the CAR T-cell therapy after 6 or 7 lines of prior therapy. And I think also lymphoma, we know that in lymphoma with standard therapy, we can already cure quite a high percentage of patients, which is not the case for myeloma. So I think the disease biology is different, the previous therapy is different, and also the age is different. So, but my personal view would be, if we move the CAR T-cell therapy to earlier lines of therapy, probably also the outcome of the patients will further improve.
And Dr. Moreau, you mentioned the Cartitude study as well. So do you have any thoughts on differences, or we talked earlier about strategies, but maybe you have thoughts on that as well?
Yes, in fact, first of all, I fully agree with Herman. In fact, we should propose CAR T, to my opinion, earlier in the course of the disease, but based on the results of clinical trials. So those trials with the early use of CAR Ts are ongoing. I think that potentially I would like to use CAR Ts in patients with a high-risk disease, in the setting of stem cell transplantation, for example, or patients with early relapse, first relapse, but relapse after a short duration of response, for example. And those studies are ongoing. So potentially we are going to learn how to use CAR-T better than as treatments for end-stage disease. Many trials are ongoing with other CAR-Ts, and we have reliable data with BB2121, as I mentioned. But CARTITUDE-1 is another CAR-T targeting BCMA, but the construct is different with two domains targeting the BCMA antigen, potentially a higher avidity, potentially a longer duration of response. But we have to be careful because the number of patients were really smaller as compared with the KARMA study. The patient population was not exactly identical. Into KARMA, we have very advanced patients with many patients with extramedullary disease, less in the CARTITUDE-1 study. So that's difficult to do cross-trials comparison. But that's true that the duration of response, the PFS seems to be slightly better, higher with CARTITUDE, with the construct from Johnson. So that's good to have new CAR-Ts tested. The issue of the persistence of CAR-Ts is a very, very important one. We know that in the KARMA study, the CAR-Ts are circulating during 9 months to 1 year and not more than this, despite the higher dose. So this is an issue, but potentially we know that we could use some agents to increase the efficacy of CAR-Ts, such as IMiDs, for example. And there are studies ongoing with the combination of CAR-Ts plus new agents immediately after CAR-Ts. So we have different options for the future.
And Dr. Nahi, you mentioned the BiTEs also. So have they been, I'm curious, I don't know if they've been used in lymphoma and leukemia, but when you look at therapies like that, and Dr. Moreau, what you were saying is maybe, and Dr. Edsler, maybe a reinfusion at some point of the CAR-T cells. So these BiTEs are longer, you know, you're on them. It's not a one and done kind of therapy. So do you want to just address, Dr. Nahi, the BiTEs in relationship to this topic or question?
Well, I'm biased probably because I use more BiTEs than CAR-T. I believe more in BiTEs. I know the nature of the myeloma disease is not a lymphoma. It's not an acute leukemia. You need to continue on treatment, otherwise you get a relapse. The BiTEs are given regularly, either once a week, once every 2 weeks, or once every third week, but it is a continuous treatment. I think this will prolong PFS and might lead to cure in some patients. Is there a big difference between the CAR-T and the BiTE? I mean, the response rate are becoming very near between the BiTE and the CAR-T. The thing that we have a median PFS with the CAR-T, but not yet with the BiTE. They are somewhat later on in development. So if I get you right, I would suggest I would wait for the results. But my feeling is the BiTE will be the future of myeloma. It's not the CAR-T. But the results are not ready yet to say that.
And I was so surprised at the last ASH meeting that there were so many BiTEs being developed for multiple myeloma. I was shocked. It was like 8 or 9, right? So I was surprised at that. Okay, well, we'll have one final question, and I don't think we can escape a COVID question during COVID. How do you see things progressing in the environment of COVID in terms of myeloma therapies? And that's a very broad question because I know some trials have been slowed for recruitment or opening back up, and we're all handling COVID in a different way depending on where we're located. But what kind of impact, I guess, do you see it has on myeloma patients, if any? And what should myeloma patients consider? And we'll have each of you share your thoughts on that. Dr. Nahi, do you want to start?
Well, Stockholm is known to be the most epidemic center in Europe. So we have a lot of experience on sorry to say that, on COVID infection in myeloma patients. The thing is, we know that a patient with a good response they most probably will survive COVID as a common population. We have a lot of deaths. I will not say anything more than that, but it's not different from the common population. What we have done, we have switched to per-oral treatment. We have given treatment at home. So we are sending nurses to the patients to give treatment at home. And the thing is, myeloma is more deadly than COVID. That we cannot stop treatment. We cannot limit the treatment. Our trials are still ongoing. We're including patients, but because these are relapsed refractory trials, especially with the bites, so the patient cannot wait for the end on the pandemic to start treatment. It's a cancer treatment that in need of, it's cancer disease that in need of treatment. So we don't have that much limitation. To start with, the first month everybody was afraid what could happen to the patient if they get the infection. Now we know that myeloma patients will survive COVID with adequate treatment. And we try to inform the patient to get isolated at home.
Great. Okay, well, that's really good input because you have had a lot of experience there. Dr. Moreau, what have you seen in France and what are you doing?
Well, we had 3 very difficult months, in fact, but now the situation is really improving. The number of new cases in France is very, very low now, and we are back to normal activity. So all the protocols are now ongoing, reopening. Patients are back to the hospitals as usual, but it is true during the 3-month period of time with a very high rate of new cases of COVID, we were really worried about patients with myeloma. We did a survey showing that the mortality, unfortunately, was higher in myeloma patients as soon as the COVID was symptomatic. So we did try to reduce the usual treatments for oral combinations so that the patients could stay at home. We have tried to move to sub-Q administration as soon as possible, for example, at home, or weekly schedules instead of bi-weekly, weekly carfilzomib, for example. We also have reduced the number of infusions of daratumamab as soon as the patients were responding to the treatment, switching very quickly to a monthly administration and so on. But now things are really improving. We are, well, finger crossed. I hope that the situation will improve during a very long period of time. But maybe that this terrible moment, in fact, will help to increase the dialogue between patients and physicians, because we had a lot of questions and patients were really involved in their decision of treatment. They were really wanted to know the plus, the minus, the benefits, the risks. So we had more discussions with the patients, and that's not bad at all. So that's a positive point.
Yeah, no, that's fantastic. I mean, the better questions that patients come in prepared with for their appointments with you, the better care they're going to get. Because if they're talking at basics, you know, like what is an M protein during your visit, you can't have this high level discussion about which therapies should I be worried about or be considering. So yeah, I applaud you. And that's why we created this tool called HealthTree University. And we were hoping to come to EHA this year and do some interviews with you, but we'll have to come and do it later in the year or whatnot. But Dr. Einsla, do you want to wrap us up with this topic and what your experience has been?
So we were quite fortunate. We didn't have a lot of myeloma patients actually being infected with COVID-19, but I can only also echo what Harald and Philip have said. I think the issue was that a lot of patients were afraid to come into the hospital and to be treated. And we really have to reassure patients that we do everything to avoid that they get affected with COVID-19 in the hospital. And we saw patients with newly diagnosed myeloma coming very late to our myeloma practice. So we saw a lot of patients coming in with hypercalcemia or deteriorated renal function. So I think it's very important to really tell the myeloma patients, COVID-19 is a problem, but myeloma is the bigger problem, and they should never avoid going to the hospital, to the treating physician, just because they are afraid of COVID-19. The myeloma has to be cared for, and I think now, when we already discussed that dexamethasone is a good treatment for COVID-19, I think the myeloma patients get dexamethasone. So I think that's very important. I think that should be transported to all our patients. A myeloma has to be treated, and you have to get in contact to your treating physician, either by phone, but go to your regular visits. We have to treat the myeloma. We have to continue the treatment. This is really the main danger for you, not COVID-19.